Parekh from Mayo Clinic, Rochester, US. He's going to speak to us on current approach to risk stratification and management of frontline chronic lymphocytic leukemia. This webinar is brought to you by Mumbai Hematology Group. It is supported by Lucian Life Sciences and managed by Perfect Square. I'm grateful to Mr. Srivastava and their team from Lucian, Mr. Yash, Mr. Kalpesh and team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Samir Parikh from Mayo Clinic, Rochester, all our discussants who are themselves eminent hematologists or medical oncologists from India, Bangladesh, and Myanmar. You participants for sparing your Saturday evening, afternoon, or morning, depending upon from which part of the world you belong to. We have today attendees from almost 27 countries. Tomorrow morning, we will have a discussion on individualized treatment of Hodgkin lymphoma. That's at 11:30 a.m. IST. And the guest speaker is Dr. Paul Brockenham from German Hodgkin Study Group, Cologne, Germany. Our discussants today, as I mentioned, include very important personalities from India, Bangladesh, and Myanmar. We have Dr. Akanksha Garg from Jodhpur, Dr. Ashok Rajoria from Gwalior, Dr. Dharma Chaudhary from Gurugram, Dr. Faraj Hijna from Mumbai, Dr. Hamza Dalal from Mumbai, Dr. Nin Mia Thanda from Myanmar, Dr. Humaira Nazneen from Bangladesh, Dhaka, Professor Ame Khan from Dhaka, Bangladesh, Dr. Monica Bopana from Hyderabad, Dr. Muralidharan from Mumbai, Dr. Sachin Jain from Gurugram, Dr. Subhaprakash Sanyal from Mumbai, Dr. Sumit Mirg from Mumbai, Dr. Sundar Shevale from Kolkata, Dr. Suneet Lokwani from Indore, Dr. Swasti Sinha from Lucknow, Dr. Yi Mon Thant from Myanmar, and of course, Dr. Amit Khurana, who is our permanent guest. And now to introduce our guest speaker for the day, Dr. Samir Parikh. You know him from the field of CLL from probably decades. He's Associate Professor of Medicine, Assistant Professor of Oncology, Division of Hematology, Department of Internal Medicine, Mayo Clinic, Rochester. He joined the staff of Mayo Clinic in 2014. He holds the academic rank of Associate Professor of Medicine and Assistant Professor of Oncology. He currently serves as the chair of the CLL disease team at that institute. He earned his Bachelor of Medicine and Surgery at the University of Mumbai, St. G.S. Medical College, Mumbai. He completed his residency at St. Francis Hospital, University of Illinois, Chicago, and a fellowship in leukemia from the University of Texas, MD Anderson. He subsequently completed a hematology oncology fellowship from Mayo Clinic School at Rochester. His research focuses on lymphoproliferative disorders, particularly CLL. He's the principal investigator of several investigator-initiated and industry-sponsored clinical trials. He's also the principal investigator of the Mayo Clinic CLL database, which includes all patients with a diagnosis of CLL seen in the Division of Hematology at Mayo Clinic, since linked to the Mayo Clinic CLL Tissue Bank. He's also a co-investigator on many studies that are funded by the NIH and the National Institute on Aging. He has given presentations both nationally and internationally and authored over 100 journal articles, book chapters, and other publications. He's a recipient of numerous awards, which include Shannon Timmins Leukemia Fellowship Award, ASCO Merit Award, Mayo Clinic Department of Medicine Career Development Award, Lymphoma Spore Career Development Award, Mayo Clinic Paul Calabresi Program in Translational Research Scholar Award, and the Mayo Clinic K2R Career Development Award. In addition to his clinical and research activities, he is also active in education and has served as a mentor to many residents and fellows, among other learners. He's an active member of the American College of Physicians, ASCO, ASH, and the ECOG ACRIN. He also serves at the Mayo Clinic representative on the NCCN, CLL, SLL, and hairy cell leukemia panel. Today, he will speak to us on current approach to risk stratification as well as the management of frontline CLL. With that, I hand over the platform to Dr. Sameer.
Thank you very much, Dr. Agrawal and members of the Mumbai Hematology Group. It is indeed an honor for me to present today. I thank you very much for your invitation. Are you able to see my slides here?
Yes.
Perfect. So again, thank you very much. Growing up in Bombay, Mumbai, this is a distinct privilege for me to be able to speak to the Mumbai Hematology Group. I hope in the next 45 minutes or so, I will walk through the history of how we've sort of did risk stratification in CLL, and how I currently incorporate these risk markers or biomarkers, if you will, in the management of frontline CLL. And I'm happy to answer any questions towards the end of the talk. So these are my disclosures. I receive research funding because of my involvement in clinical trials, as well as honoraria for consulting activities and advisory board meetings. But per Mayo Clinic policy, all of these dollars go to Mayo Clinic. So I had been invited to give a talk on monoclonal B-cell lymphocytosis earlier this year, and I'll just revisit some of that in today's talk, because I think this is a little bit confusing, particularly to trainees and even people who do hematology, because this is made confusing over the last several years of these three interlinked entities, MBL, CLL, and SLL, and how these are distinguished from one another. And so I'm sure I don't have to tell you as hematologists how CLL is diagnosed. It's typically based on a peripheral blood flow cytometry study. And on your left upper corner here, you can see the classic peripheral blood smear that shows the presence of smudge cells. And here in a high power field, you will see these small lymphocytes that are increased in number. And these lymphocytes are obviously larger compared to the red cells in the peripheral blood smear. And these smudge cells are really an artifact that happen when you do a peripheral blood smear during the preparation of the smear. In the peripheral blood, these are obviously intact lymphocytes. And then on the right panel here, you see a flow cytometry study panel that actually will show the presence of aberrant expression on these B cells that typically express CD19. These are kappa light chain restricted. And these cells, generally, when they are B cells, which are CD19 expressing cells, should not have CD5 expression on them. And so when you see the aberrant expression of CD5, CD19, and then if these B cells are also CD23 positive, then that's sort of typical for a CLL immunophenotype. And then now we can also actually identify these cells with the use of CD200, which is also uniformly expressed on the surface of CLL cells. And so the current definition is that there should be a monoclonal expansion of these B cells that express these markers. And then the clonal B lymphocyte count should be greater than 5,000. And that really is the definition of CLL. And so here is a typical sort of peripheral blood flow cytometry result that I get on my patients when I get a flow cytometry result. And here you can see that the absolute clonal B cell count was calculated to be 6.7. And when it's greater than 5,000, or this is 6,700, that's the definition of CLL. Now, if the clonal B cell count is less than 5,000, and if there are cytopenias with marrow infiltration, then that still becomes a diagnosis of CLL. However, if there are no cytopenias, no lymphadenopathy or hepatosplenomegaly, then that by definition is what is called as monoclonal B-cell lymphocytosis, which is the precursor condition to CLL. On the other hand, if the absolute clonal B-cell count is less than 5,000, and a patient does not have cytopenias, but does have lymphadenopathy or hepatosplenomegaly, either on exam or by CT scan, then that by definition becomes small lymphocytic lymphoma. And this is essentially the same disease process, thought to be more of a lymph node-based presentation of the disease, but it's approached in the exact same fashion. There are some differences, and we'll get to those as we talk about treatment. But it's important to remember that patients who don't have a clonal B cell count of greater than 5,000 yet have lymph node enlargement and a biopsy shows the CLL immunophenotype of B cells, and that's a definition of SLL. And so, of course, with MBL, we have now been able to change the definition over the last several years, again, adding to some of the confusion here, where initially the definition was really based on the absolute lymphocyte count of 5,000. But over the last several years, that goalpost has been moved to the right, where instead of an absolute lymphocyte count, it's really the B cell count that has now been called as 5,000 as the cutoff between MBL and CLL. And so what this has done is, because obviously B cells are a component of the lymphocyte count, that's why this goalpost shifted to the right. And therefore, several patients who were previously called as CLL were now classified as clinical MBL. And then the further classification for MBL became where patients who had a B cell count of between 0.5 to 4.9 were called as high count MBL. These patients typically have lymphocytosis, whereas those with low count MBL have a total absolute clonal B cell count of less than 0.5. And these patients typically don't have any lymphocytosis, and these are identified on screening studies, meaning healthy individuals who donate blood, or where there are population-based studies done, is where this B cell count can be identified. And if it is less than 0.5, then that's consistent with low count MBL. And of course, I think these are all B cell counts. Truthfully, this should actually be clonal B cell counts, which is even a smaller subset of the total B cell count. And therefore, the true goalpost, in my opinion, is a little bit even further to the right of a total B cell count of 5. Regardless, this is how we really if we really think about a diagnosis of MBL, CLL, and SLL, essentially the same disease entity. And then there is obviously a risk of MBL progressing to CLL or SLL requiring therapy over time. And that typically is about 1 to 2% per year. So, CLL and SLL, how about the current sort of approach to diagnosing it and talking about risk stratification and prognosis in these patients? So I'm sure all of you have seen patients that have been referred to you because these patients had a CBC for an unrelated reason. They are generally asymptomatic, and then there is an incidental lymphocytosis detected. Some patients may have lymph node enlargement as their initial presentation, but then additional workup is done, including flow cytometry study, and that perhaps shows the presence of these clonal B cell population, and therefore the patients are referred to a hematologist. Now, in general, once you've seen a patient with a new diagnosis of CLL, you examine them, you assign a rise stage to the patient based on physical examination and the CBC parameters. Nothing else needs to be done if the patient doesn't meet the typical indications for treatment. However, the clinical course of these patients is very heterogeneous, where some patients have faster disease progression, others don't. And I think we try to counsel our patients based on many of the risk markers to better predict when the disease is likely to progress over time. And I think every place has a different approach of doing this, but we typically will try to obtain all the prognostic information at the time of diagnosis to be able to counsel our patients as to what to expect in the coming years. And of course, the best sort of and the most and the oldest, I should say, prognostic marker, if you will, is the rise stage at diagnosis. And we can also use the Binet stage. That's slightly different from the rise stage, but essentially they tell us the same thing. So in rise stage classification, patients who have rise stage 0 have lymphocytosis only. Rise stage 1 is where patients have lymph node enlargement. Rise stage 2 is where they have typically organomegaly, but that's generally splenomegaly. And rise stage 3 and 4 are considered advanced stage CLL, where you have anemia with a hemoglobin of 11 or thrombocytopenia with a platelet count of less than 100. And as you can see, this is sort of the survival that was described by Dr. Rai in his original publication many decades ago. And then we recently updated this from the Mayo Clinic database, where you can see that there has been substantial improvement in the outcomes of patients with advanced RI stage disease, not so much in patients with early stage disease, which is not surprising because we don't really treat these patients when we first see them. But regardless, this is a very nice way of predicting how patients are likely to do over time. But again, this is a snapshot in time. It's a cross-sectional sort of examination of a patient. We have no idea of how long the patient has had the disease for when we first see them. And so this gives some understanding of whether we should act on with this information at the time of initial evaluation, but it doesn't really tell us how a patient's journey is going to be with CLL, particularly if they have early stage asymptomatic disease. And so, I was at MD Anderson, and I had the good fortune of working with Dr. Michael Keating, who really influenced a lot of things that I still think about when I see CLL patients. And he would have this running joke where, in CLL, we love talking about prognosis, and there is always a prognostic marker of the month. And so, every month you will find a new publication with something that comes out that will say it's better than the last thing that came out last month. And so, here is just a menu of several different clinical, laboratory-based parameters and molecular markers that can help identify which patient is likely to have faster disease progression. Again, these are all prognostic markers, meaning they will tell you which patient is likely to have faster disease progression or slower disease progression. Many of these markers are actually predictive biomarkers as well, meaning the treatment that you choose for your patient will actually depend on the presence or the absence of these biomarkers. And it's very important to distinguish between a prognostic biomarker and a predictive biomarker, because a prognostic biomarker is generally not something that you will worry about when you're picking treatment. Whereas when you're trying to pick treatment options for a patient, for example, if you're looking at gene mutations, IGVH mutation status, these things matter. It is also important to remember that these things change with the type of treatment options that become available, and we'll touch upon these as we go through the treatment options. So here is a classic prognostic marker, IGVH mutation status and outcomes. These are initial publications that came out in, over 2 decades ago. And you can see that patients who had unmuted IGVH genes with these dotted curves here and the solid line here had poor overall survival compared to patients with mutated IGVH genes. And this is sort of a very powerful prognostic marker that describes how patients do with the presence of these unmutated IGVH genes. Similarly, the CLL FISH profile is also something that came out around the same time. And that actually also showed that patients who have the high-risk genetic marker deletion 17p, here shown in the solid black line, these patients have a poor survival compared to those with the other markers. The best outcomes were noted in patients who had deletion 13q as the sole abnormality, which is shown up here. And then patients with deletion 11q were over here, and those with no abnormalities or with trisomy 12 were in the intermediate sort of risk marker category. Now, a lot obviously has changed since the introduction of the IGVH mutation status and the CLL FISH. These are all talking about overall survival, and obviously overall survival is completely dependent on the types of treatment that a patient is able to receive. And so these have changed over time, and we'll look at some of the survival curves with our contemporary treatment options. But certainly these were the initial studies that actually predicted how patients are likely to do based on some of the molecular biomarkers that continue to be used to date. So fast forward about a decade, and we started learning about next generation sequencing studies and the presence of hotspot mutations that may be present in CLL patient cells, where you can see that TP53, SF3B1, MYD88, and ATM were the most commonly mutated genes that were found. And these were all have continued to play an important role in our ability to pick treatment options for patients. But again, these were prognostic in predicting time to first therapy. And so if you see a patient who is newly diagnosed, doesn't need treatment, here is Mayo Clinic data of over 440 patients where these patients did not need treatment when they were first seen, and they all underwent a 59 gene panel next generation sequencing study to look for recurrent mutations. And as you can imagine, CLL is a disease where there are not a lot of mutations to be found, unlike many other hematologic malignancies or even solid tumors where there are multiple mutations found. For example, lung cancer, the number of mutations is really high. But here, a third of the patients had no mutations, approximately a third had one, and another third had 2+ mutations. And you can see that in the overall cohort of patients, based on the number of mutations or the genomic complexity, patients were able to segregate it into when they first needed treatment. And so patients that did not have any mutations had a lower time to first therapy compared to those with a mutation load. The TML is called tumor mutation load of one mutated gene, versus here in red, if you have 2+ mutated genes, the time to first therapy was much shorter, suggesting that it is really the amount of genomic complexity that would actually predict how fast someone's disease is likely to progress over time, needing treatment. Now, it's very hard to get these next generation sequencing studies paid for by insurance or even be available on a routine basis. And so what we typically do in our clinic, and this is again Mayo Clinic data, where we see all our patients who first are diagnosed with CLL and who don't meet indications for treatment, then we will get all of these tests, including a CLL FISH profile. We try to get a TP53 mutation. This is typically done by Sanger sequencing, at least at Mayo Clinic, which is not as sensitive as the next generation sequencing, but at least can give you some information about the prognostic ability of this particular biomarker to predict outcomes. We also get IGVH mutation study, serum beta to microglobulin, rise stages by physical exam and by CBC, and of course, a patient's age. And then we assign points based on each of these biomarkers, and this is essentially what is called as the CLL International Prognostic Index. Now, the CLIPI or the CLL-IPI was actually developed to predict overall survival. However, we have actually shown, as is seen here on the graph on the right, that the CLIPI is actually also very helpful in predicting time to first therapy in patients who don't meet indications for treatment. And this is something that we routinely do and then counsel our patients based on the total score that goes from either 0 to 10. So a patient can be in the low, intermediate, high, or very high risk CLIPI scores. And then based on what their CLIPI score is, we would then counsel the patients about what their 5 and 10-year estimated risk of disease progression are. And so if I see a patient that has a low CLIPI risk score, then I will say there's about a 1 in 4 chance that you will need treatment in 5 years, and about a 4 in 10 chance that you will need treatment in 10 years. And you can see that this risk is substantially higher in patients who have high and very high risk of disease progression. And so again, this is one of those things where not everyone truly believes in doing this at the time of diagnosis, but we strongly feel that because we have the ability to get these tests done, and because they segregate patient outcomes so nicely, it is important to do this at the time of diagnosis. Now, I also mentioned that in contrast to treatments that change all the time and new treatments come around, and that changes outcomes, time to first therapy is an outcome that will not change, because obviously a patient hasn't received treatment, right? It is time between diagnosis and the need for first treatment. And so this, we think, will remain prognostic and important regardless of how much improvements there are in the therapeutic armamentarium, so to speak, against CLL. And so again, this is one of the standard things that we would do for all our patients. And so if a patient doesn't meet criteria for therapy at the time of initial diagnosis, This is our current approach. If we have a patient who has low or intermediate risk CLL-IPI, we will typically advise monitor for disease progression every 6 to 12 months. And if they have high or very high risk CLL-IPI, we would offer them participation in early intervention clinical trials to see if we can improve outcomes in these patients, but otherwise see these people very closely every 3 to 6 months, because the median time to first therapy is about 1.5 years. Combined in the high and very high risk CLL group of patients. So, I'll just also mention that recently the German CLL study group presented the final analysis of the CLL12 study, which took patients with high risk disease. It was not according to the CLL, it was a different index that they used to treat patients on that study. And they were randomly assigned to either Ibrutinib or placebo. And although Ibrutinib improved the progression-free survival, which is not surprising because you're treating half the patients and you're not treating the other half, there was no difference in overall survival. And so the current sort of paradigm for treatment, even in the high-risk patient population, is continued observation and no active intervention. I think it's equally important that all of these patients who don't meet indications for therapy continue to receive age-appropriate cancer screening, given the increased risk of secondary malignancies in these patients. These patients should also get an annual dermatology visit. And of course, they should all get appropriate vaccinations to reduce the risk of infections. It's important to avoid live vaccines. So, what about frontline therapy in these patients with CLL? So I'll just provide a quick historic perspective. So, prior to 1991, chlorambucil and cyclophosphamide were the only treatments that were available, and patients who stopped responding had poor survival. And then Dr. Mike Griever from Ohio State and Dr. Michael Keating actually led some of the initial phase 2 studies in patients who had alkylate or refractory CLL, and using fludarabine, which was sort of the in thing in 1990s. And this study showed very good outcomes and quickly led to an accelerated approval of fludarabine in relapsed CLL. And therefore, the next thing that was done was fludarabine was taken into the frontline setting, where patients with untreated but symptomatic CLL were randomized to either fludarabine, fludarabine, chlorambucil, or a combination of fludarabine and chlorambucil. And you can see that there was excessive toxicity with the fludarabine and chlorambucil arm, and so that was stopped. But in the patient comparison between fludarabine and chlorambucil alone, fludarabine showed better outcomes. And this was sort of an initial publication in NEJM that showed that fludarabine was very effective. And so this quickly led to the next study where fludarabine was compared alone to fludarabine and now cyclophosphamide. And here you will see that patients who received fludarabine and cyclophosphamide did much better compared to fludarabine alone. And this was the ECOG 2997 study. Along the way, rituximab was approved for relapsed low-grade lymphoma, and therefore a CALGB study was done where patients received either fludarabine with concurrent or delayed rituximab, and patients who received FR, which was given in a concurrent fashion, had better outcomes compared to those who received delayed rituximab, suggesting that adding rituximab would be better. And so this quickly led to the next study, which was a pivotal study that Dr. Michael Halleck presented, which compared FCR to FC. And you can see that in the green line, which was the chemo immunotherapy arm, that showed an improvement in the progression-free survival and even in overall survival compared to FC alone. And this quickly became the standard of care in patients with young patients with CLL. Subsequently, the CLL10 study was done, which compared FCR to BR. Here you will again note that FCR was much better compared to BR. However, toxicity in patients over the age of 65 was much higher with FCR compared to BR. And therefore, we still think about FCR as being generally used in patients who are less than 65 or perhaps less than 70, and BR in the older patient population. And then in our very old patients, meaning people who are typically over the age of 70 or 75 and who have several comorbidities, the CLL11 study actually showed that the combination of chlorambucil and obinutuzumab, which is a new sort of glycoengineered anti-CD20 antibody, was far superior compared to chlorambucil and rituximab in the frontline management of CLL, and chlorambucil and rituximab was superior to chlorambucil alone. And so this sort of led the chemoimmunotherapy field in the first sort of half of the last decade. And so, as I started my journey personally taking care of CLL patients as staff, in 2013, 2014, it was a pretty clear sort of thing that if you're less than 65 FCR, if you're between 65 and 74 BR, and then if you're over 75, you would do chlorambucil and obinutuzumab-based treatment. But at that time, sort of the questions were, how can we improve outcomes? And there were a variety of drugs that were thought to be added. You could use ofatumumab, you could use mitoxantrone, alemtuzumab was tried, but there was, a lot of toxicity with many of these treatments, with the risk of secondary myeloid neoplasms, risk of Richter's transformation. And so this was obviously not an ideal situation. And of course, patients with high-risk genetics, including those with deletion 17p, the median PFS with the best frontline therapy at the time, FCR, was about 15 to 18 months. And so this was clearly a optimal response in our high-risk patients, and it begged for improvement. And so how about our contemporary approach? So, I'm sure you've all sort of read this excellent article from Dr. Jan Berger in NEJM talking about CLL and the microenvironment and how this has influenced our treatment options for patients with CLL. And so here you will see that, the microenvironment is where there are nurse-like cells and T cells and other supporting cells that actually provide signals to the proliferating CLL cells to survive and proliferate. And there are a variety of treatment options, including BTK inhibitors, BCL2 inhibitors, and anti-CD20 antibodies that have all been used to treat patients with CLL with excellent outcomes. So one of the first studies in the frontline setting is the so-called RESONATE study that compared chlorambucil to Ibrutinib in older patients with CLL, Ibrutinib being the first-in-class BTK inhibitor at the time. And you can see that it improved progression-free survival substantially compared to chlorambucil. It actually also led to an improvement in overall survival compared to chlorambucil. And of course, it's no surprise that this drug was quickly approved in the frontline management of CLL. Now, I told you about IGVH mutation status and how that played an important role in the prognosis of patients with CLL in the chemoimmunotherapy era. But it quickly turned out that with Ibrutinib and other BTK inhibitors, it didn't matter whether you had mutated or unmutated IGVH genes, the outcomes were similar, suggesting that if you do continuous BTK inhibition, then it wouldn't matter whether you have mutated or unmutated IGVH genes because the clone is able to be suppressed with continuous BTK inhibition. So this then led to sort of trials that actually compared Ibrutinib to the more contemporary or the more powerful, if you will, treatment options for CLL. And so this is the E1912 study that was led by the ECOG Akron group. Here, patients less than 70 or young patients with CLL were randomly assigned in a 2:1 fashion to either Ibrutinib and rituximab or FCR, which would be the standard of care. And because it was known that patients with deletion 17p would have an inferior outcome with FCR, those patients were excluded from this study. So a total of 519 patients were randomly allocated 2:1 to either the Ibrutinib and rituximab or the FCR arms. And you can see that here at 3 years, the progression-free survival was far superior in the Ibrutinib and rituximab arm compared to the chemoimmunotherapy arm with FCR, suggesting that this is a much better treatment option. In fact, there was also an improvement in overall survival with the use of Ibrutinib and rituximab compared to FCR. And so this sort of study led to the approval of Ibrutinib and rituximab in the frontline setting for young CLL patients who do not have deletion 17p, and quickly surpassed the use of FCR in typical management of CLL patients in the frontline setting. Again, over here, in this study, patients who had unmutated IGVH genes actually had a far superior PFS compared to FCR with the use of Ibrutinib and rituximab here in red. And it was traditionally thought that patients with mutated IGV8 genes would actually do much better with FCR. There are lots of studies, particularly from MD Anderson, showing that. But in this study, even in the mutated IGV8 patients, eventually with longer follow-up, it turns out that ibrutinib and rituximab was associated with a superior progression-free survival compared to FCR. And therefore, in our practice, we typically do not use FCR for anybody, unless for whatever reason we are unable to get insurance approval for any of the newer agents. So a companion study was done for older adults with CLL, where these patients were greater than 65 years of age, and they were randomly assigned to either ibrutinib and rituximab, or bendamustine and rituximab, which would be sort of the standard of care for older adults. And this is the Alliance protocol. And then patients who had disease progression on BR would be allowed to cross over to single agent ibrutinib if they had disease progression. And so here you will note that patients who received either ibrutinib containing regimen had a superior progression-free survival compared to bendamustine and rituximab. Importantly, there was no difference in PFS between the use of ibrutinib alone or ibrutinib and rituximab, suggesting that the anti-CD20 antibody did not add much. And so if I was to use ibrutinib in the frontline setting in older patients with CLL, I would typically use it as a single agent and not combine it with the anti-CD20 antibody. But again, this is a PFS benefit. And certainly that has changed how we approach the older patient population with CLL as well, because that study led to the approval of ibrutinib across the board for all patients, regardless of age. Of course, over time, we've also now come to appreciate the toxicity of ibrutinib. Our patients stay on ibrutinib for the long term, for many, many years because of the excellent outcomes. And unfortunately, we have now become accustomed to seeing patients developing side effects, including atrial fibrillation, bleeding, hypertension, arthralgias, infections, diarrhea. And you can see over here that these can range anywhere from 7 to 15%, 20% arthralgias. And these can be quite problematic. If a patient stops treatment because of toxicity, then I think it's important to remember, as shown in the ECOG E1912 study, that if a patient has received therapy for some time and is in a good remission status, even if it's a partial remission, you don't have to treat that patient right away. In fact, the median time to therapy, if a patient stops treatment for toxicity, is about 2 years. And so in a lot of my patients, if I run into toxicity issues with the patient, and if they've received treatment for some time, I will try to reduce the dose of ibrutinib or any of the other BTK inhibitors to get away with the toxicity issues. But if I'm forced to stop treatment, I wouldn't necessarily switch the treatment to something differently. I would try and observe the patient without any treatment to see if I can get away without treating them with anything for a while. And at least this study suggests that you can get up to 2 years worth of treatment-free interval before they need something else. So because of these toxicities of BTK inhibitor with ibrutinib, there were second generation BTK inhibitors being developed. And so here is a Chemo map, and this sort of is a map that shows all the enzymes that are inhibited by ibrutinib. And so obviously this drug is not very specific, because in addition to BTK, it also inhibits many other enzymes, and it is thought that all of these other targets are the ones that cause many of the side effects that patients experience when they receive treatment. And so you will see here that other BTK inhibitors such as acalabrutinib and zanubrutinib, which are now approved for CLL in the frontline and the relapse refractory setting, are more specific, acalabrutinib compared to zanubrutinib even, where they have much more specificity for the BTK protein and kinase, as opposed to many of the other kinases that can cause some side effects. And so this is sort of a preclinical model. So what about in the clinic? Did this pan out? And so, I'll talk about how the comparative efficacy is, but because this was thought to be the case for acalabrutinib and zanubrutinib, these were now tested in the frontline setting. And here is an the Elevate-TN study, where patients were randomly assigned in the treatment naive setting to either acalabrutinib and obinutuzumab or acalabrutinib alone, or the combination of chlorambucil and obinutuzumab in patients who had progression disease, and chlorambucil and obinutuzumab were then assigned to the acalabrutinib treatment arm. Patients were allowed if they had deletion 17p or if they had a SIR score of greater than 6 or creatinine clearance of less than 70. And again, these are all treatment naive patients. And as you can see in the progression-free survival curve here, patients who received the combination of acalabrutinib and obinutuzumab had a superior progression-free survival compared to even those who received single-agent acalabrutinib compared to patients who received chlorambucil and obinutuzumab. This has now been updated, and now at the 5-year mark, it appears that the difference between acalabrutinib and obinutuzumab compared to acalabrutinib alone is even bigger. And so I think it is plausible that obinutuzumab is a much better and a much more potent CD20 antibody when it is combined with a BTK inhibitor. So in contrast to ibrutinib versus ibrutinib plus rituximab, it appears that perhaps obinutuzumab is a better combination anti-CD20 antibody with a BTK inhibitor, and increasingly we find ourselves adding obinutuzumab to when we use acalabrutinib. But certainly these results are supportive of the use of a BTK inhibitor compared to chemoimmunotherapy with chlorambucil and obinutuzumab. So a second study, which was recently presented, looked at what is called as the Sequoia Study, where patients were randomly assigned to either zanubrutinib as a single agent or bendamustine and rituximab, which would be again standard therapy in a patient in the frontline setting. And this was cohort 1. Patients with deletion 17p were excluded from this study. And here you will see that roughly 250 patients were randomly assigned to either the zanubrutinib arm or the BR arm. The vast majority of the patients were in their 70s. The one thing I'd like to point out in the baseline characteristics of these patients is that despite the exclusion of patients with deletion 17p by FISH, you will note that about 6% of patients in each arm had a TP53 mutation. And so what I want to drive home the point here is that there is a small proportion of patients, about 5%, that have a TP53 mutation, and these patients do equally poorly as patients with deletion 17p. And so if you only get a CLL FISH panel and not check for a TP53 mutation, you will miss these patients. And obviously these patients are better served by any of these novel agents as opposed to chemoimmunotherapy. But it's not surprising to see that patients with continuous zanubrutinib therapy had a better progression-free survival compared to BR. And this was even the fact in patients who had unmutated or mutated IGV8 genes. Both of these subgroup of patients had a better outcome with continuous zanubrutinib compared to BR. And so this study, along with the Elevate-TN study, actually led to the approval of zanubrutinib in the frontline setting with Sequoia, and acalabrutinib in the frontline and both even the relapse setting for acalabrutinib. And so, as referring to the toxicity, and we looked at the kinome map of acalabrutinib and ibrutinib, and we think that acalabrutinib is better. And here are actually patient-level data from a head-to-head study comparing acalabrutinib to ibrutinib in relapse CLL. And you will see that the outcomes of patients was pretty similar, meaning this is PFS, and it was no different between acalabrutinib and ibrutinib. However, this is just one example of a risk of atrial fibrillation, and you will see that there was a lower risk of AFib with the use of acalabrutinib compared to ibrutinib, suggesting that truly it is likely a better drug, and it prevents patients from developing these cardiac adverse events. And a similar study was done called the Alpine Study that was recently published, where patients were randomly assigned to zanubrutinib or ibrutinib. Here, actually on the right top, you will see that there was an improvement in PFS with the use of zanubrutinib compared to ibrutinib. But again, the more important sort of finding was a lower risk of atrial fibrillation with the use of zanubrutinib compared to ibrutinib. suggesting that whatever was seen in the Kino map with a better and a more selective profile of these new BTK inhibitors actually translated into the clinic, where the efficacy was similar or maybe better compared to Ibrutinib and lower toxicity. And so because of these data, we typically don't prescribe Ibrutinib anymore, and we try to go to one of the second generation BTK inhibitors if we are going to use a BTK inhibitor in our patient population. So one of the limitations of BTK inhibitors is continuous duration of therapy. So what about shorter duration of treatment? So here is the CLL14 study, which actually used venetoclax in combination with obinutuzumab and compared it to chlorambucil and obinutuzumab in an older patient population. Patients with deletion 17p were allowed. Obviously, that's a limitation of this study because we already know that patients who have deletion 17p would not do very well with chlorambucil-based treatment. But the recent sort of publication looking at the outcomes of these patients is excellent, and you will see that patients who received venetoclax and obinutuzumab, the median PFS was about 76 months. And so that's over 6 years, which is wonderful because if you look at when these patients finished treatment, that was only for 12 months. And then the rest of the time that the patients enjoy without any disease progression is really the time when they don't need any treatment at all. And so this time is really valuable to patients. It is they don't have any longer term toxicity with ongoing therapy. There's also less financial toxicity because you're not paying for drug as opposed to continuous BTK inhibitor based treatment. And so I think this is a very good treatment option. It's now FDA approved and is available, and we use it routinely for our patients. And you will see that chlorambucil and obinutuzumab obviously does not perform as well. There was no difference in overall survival between these two treatment arms yet because there was crossover allowed. BCL2 inhibitors or venetoclax have their own issues, but I think the vast majority of these are manageable. So the risk of tumor lysis syndrome with venetoclax ramp up in the CLL14 study was essentially zero. There is a risk of neutropenia, but that can be mitigated by lowering the dose or giving Neupogen or Neulasta. And then there is mild diarrhea that is seen, but again, I think that can easily be controlled by modifying the dose. And again, the best part is that with frontline therapy, the duration of treatment is only 1 year. And so patients would be done by that time. And most patients tolerate this treatment exceedingly well. And so Nitin Jain and colleagues from MD Anderson actually decided that, we probably don't need the antibody. So obinutuzumab was excluded from the combination, and he and others combined Ibrutinib and venetoclax in a phase 2 study with excellent outcomes. Patients receive Ibrutinib for 3 months as a lead-in to prevent tumor lysis from happening. And then in month number 4 is venetoclax is when it is added. And you can see that this leads to excellent undetectable MRD status in the bone marrow in roughly 70% of patients, with almost 100% complete remission with the use of time-limited therapy of 15 cycles of treatment and up to 24 cycles with the combination of Ibrutinib and venetoclax. And then this led to the so-called Captivate study, where excellent results were reproduced, essentially mirroring what was seen in the initial phase 2 study conducted at MD Anderson. And so these led to a registration study with the combination of Ibrutinib and venetoclax, comparing it to chlorambucil and obinutuzumab. And again, it is no surprise that Ibrutinib and venetoclax was associated with a superior progression-free survival compared to chlorambucil and obinutuzumab. And this was approved by the European Medicines Agency, but not by the FDA, primarily because of toxicity issues. So there were several patients who unfortunately had cardiac events with the use of Ibrutinib. This was a older patient population. And so I believe that it will likely not be approved in the US, although I know that a lot of people in Europe do use Ibrutinib and venetoclax, particularly in the young patient population. I think it's a pretty good treatment option. and also particularly among those patients who have high-risk genetic features such as deletion 17p. And then finally, recent data from the CLL13 study became available, and this study is actually very interesting because this is one of the first studies that actually compared rituximab and venetoclax in the frontline treatment arm compared to venetoclax and obinutuzumab. So the question always was, is obinutuzumab really a better antibody compared to rituximab in a frontline program in a head-to-head study? And this is really where it was done. The other two arms of the study were either FCR or BR, or the fourth arm was a combination of obinutuzumab, ibrutinib, and venetoclax, so all three agents given together. And this is a total of 920 patients. Patients who were less than 65 got FCR, greater than 65 got BR if they were assigned to this treatment arm with a primary endpoint of undetectable MRD. And you will see that the results are quite interesting. Patients who received chemotherapy with either FCR or BR actually had an undetectable MRD of about 52% in the peripheral blood. With venetoclax and rituximab, it was not much higher. It was almost similar, which was disappointing, but also suggestive of the fact that obinutuzumab is really the better CD20 antibody, where the undetectable MRD rate was 86.5%, not substantially different with the use of all three drugs at 92%. But more importantly, if you see on the right, there was a substantial difference in PFS between the chemotherapy or the venetoclax rituximab arm and either of the obinutuzumab containing arms. There was no difference with the addition of ibrutinib to venetoclax and obinutuzumab. And so this obviously will need to have longer follow-up to see how this pans out. But at least for now, it appears that obinutuzumab is perhaps the better antibody in combination with venetoclax, and certainly, if available, should be preferred in the use or the management of frontline CLL. So TP53 disruption, I think, is an important thing. We talked about deletion 17p over here, but what we've also learned is that TP53 mutation in the absence of deletion 17p has poor outcomes in the same fashion, including if it is present as a subclonal mutation. And so again, it's important to check for both deletion 17p by FISH and TP53 by sequencing to know the presence of this, because about 5% of patients will only have a TP53 mutation, and if you don't test for it, you won't find it. So, what about treatment outcomes? So we typically would recommend continuous BTK inhibitor-based therapy for patients who have TP53 aberration, because on the right, you will see that these patients have a far better progression-free survival, which about, at 6 years is about 60% with ibrutinib, compared to if you use fixed duration venetoclax or obinutuzumab-based therapy, the median PFS in these patients was about 4 years. So it's not bad 4 years in a patient with high-risk deletion 17p and TP53 mutation. You will remember that I mentioned with FCR, with TP53 mutation or del 17p, the median PFS used to be 12, 15, 18 months at best. And here we have with 1 year of fixed duration venetoclax obinutuzumab of close to 4 years of median PFS. And on the right, median PFS was not reached. It's over 6.5 years. So clearly, these treatment options are much better for this high-risk subgroup of patients, but this is cross-trial comparison. However, we prefer the use of continuous BTK inhibitor if we can in a patient with TP53 aberration. And finally, just real quick, I'll talk about MRD. There is the European Research Initiative on CLL, so the ERIC recommendations of looking at MRD. The current threshold for definition of MRD in CLL is 1 cell in 10,000 leukocytes, so that's 10 to the power minus 4, which is different from acute leukemia, from multiple myeloma, etc. And we also now have far more sensitive techniques, such as clonoSEQ, which is an NGS-based method to look for residual disease, and that can go down to 1 in a million cells, which is 10 to the power minus 6. And this is what a typical clonoSEQ report will look at. They will identify a tracking and an MRD determination. They will actually even tell you what the mutation status is. and then they will give you if there are any residual cells remaining per million. But I think this remains still investigational and is not ready for prime time. However, there are several studies that are now trying to understand if MRD can actually guide the duration and intensity of treatment. But you can already see that the bone marrow undetectable MRD rates are in excess of 70–80% for the vast majority of the contemporary treatments that have been used, and these are much better than what we can get with chemoimmunotherapy. And here are some data from the CLL4D study that shows superior progression-free survival with the use of undetectable MRD compared to those that have low or high MRD. And so again, whether we should act on MRD to influence the duration and the type of treatment, etc., those are still being investigated in clinical trials right now. So what next? And I think these are several phase 3 clinical trials that are currently undergoing, where, I'll just draw your attention to the ones in red here, where, for example, the CLL17 study is going to compare continuous Ibrutinib to Ibrutinib and venetoclax as fixed duration therapy to Ibrutinib, venetoclax, and obinutuzumab as fixed duration therapy. This trial has completed accrual, and we are obviously eagerly awaiting these results. But then there are many other trials that are currently ongoing and are awaiting results. But I'll just show you that an example that more may not always be better. So these are data presented by Dr. Voyage at the ASCO annual meeting this year, where in this older alliance patient population, where Ibrutinib and obinutuzumab was compared to Ibrutinib, obinutuzumab, and venetoclax, the triplet was actually associated with a worse progression-free survival and a trend towards worse overall survival, likely because of increased infections. And so I think we have to be careful in how we tailor our treatment options for our patients. Again, more may not always be better. And so this is my final slide. This is our current approach of how we manage frontline patients with CLL. So again, clinical trial enrollment is obviously preferred. But the first thing we do is we look at the TP53 status. I said, again, by CLL fission, TP53 mutation testing. If there is any evidence of TP53 disruption, BTKI plus or minus obinutuzumab is our preferred approach. Generally, we would use either acalabrutinib or zanubrutinib. If there is no TP53 disruption, I think in a fit young patient, venetoclax and obinutuzumab really is the way to go, because it is tolerated very well and it is associated with an excellent outcome. In patients where they may be unfit or they may have difficulty in tolerating the venetoclax, then I think single agent BTK inhibitor based treatment is also an equally effective treatment option. If you're going to use Ibrutinib and venetoclax, I would recommend that only be done in younger patients who are fit, because I think there's a high toxicity burden in older patients who receive Ibrutinib. So with that, I'd like to thank you for your attention, and I'm happy to answer any questions.
Thank you so much, Dr. Sati. That was fantastic, complete overview. You began from the basics. You gave us updated information on what's happening on the research level today. So we'll ask our colleagues over here to ask questions to you or share their experience. All right, this chat box has no question at the moment. Yes, Farah?
Sorry. Good evening, Dr. Parikh. That was really an absolutely excellent lecture, especially the way you took us through the whole treatment from how it started, in fact, how we all started to what it is now. I have two questions. You said regarding the limited venetoclax plus Ibrutinib is not approved because of the toxicity. So then why not do venetoclax ACAL?
Yeah, certainly you can do acalabrutinib plus venetoclax or even ibrutinib plus venetoclax. There is limited data with this combination yet, but I understand that there are several phase 3 clinical trials that are ongoing, and so hopefully that approval will come through once those trials read out. I know, anecdotally, many of our colleagues here in the US actually use acalabrutinib and venetoclax. I practice at Mayo, we are obviously very conservative. We try to stick to the approval, the way things come through. And personally, I also believe that unless I see randomized data that show that Ibrutinib plus venetoclax or acalabrutinib plus venetoclax is better compared to venetoclax and obinutuzumab, I would much rather keep a BTK inhibitor as salvage therapy for future use, because I can then obviously go and use that drug once venetoclax and obinutuzumab has stopped working. And so that's why I want to see randomized data that clearly show the benefit of a BTK inhibitor and a BCL2 inhibitor compared to venetoclax and obinutuzumab. So until I see that, I'm a little bit hesitant to use the doublet oral combination. Having said that, I don't see anything wrong with doing that. I think it's very effective. It's very convenient because it's an all oral regimen. We don't have to use any infusions. Patients love this. And so I don't fault people who do that, but I just think that, we need to see randomized data.
Okay. And a little out of the way from your lecture, but we find a lot of patients of CLL who have these hypersensitivity skin reactions, which are very debilitating. And there's no other indication for treatment. So how do you manage those? How often do you see and how do you manage those?
Yeah, that's a good question. I think, bug bites, mosquito bites, these are very, very problematic for patients, particularly here in the summer months. I like to stage these patients, and if I can treat them, for CLL, I will treat them, because if they really have a lot of hypersensitivity reactions, then I will treat them. I may not go the full distance, meaning I may not use my most effective therapy if I just want to get away with some debulking, because in my experience, what I've seen is if you can get the disease slightly better controlled, then all of these hypersensitivity reactions get better. So I might consider the use of single agent obinutuzumab in these patients for an abbreviated course, like maybe 3 months or so, to get them debulked to a certain extent and hopefully prevent these hypersensitivity reactions from happening. This is completely non-evidence-based personal recommendations, but that's something that I find helpful. But I also want to make sure that I reserve, the good treatment options for the future. So I'm not quote unquote burning them when I'm treating them for not a traditional sort of indications to treat, if you will.
Yeah, because they are really very debilitating for the patient, especially when there's no other indication to treat. Thank you.
Right.
Thank you, Farah. Dr. Samir, about this second primary malignancies, besides annual routine checkup, how aggressive are you on investigating them or searching for these at asymptomatic?
Yeah, no, so I think, the increased risk of second malignancies is a challenge. I think, we will counsel our patients that you need to make sure you get your colonoscopies done, mammograms done, and all the other age-appropriate health screening measures done, so you don't forget all of those things. I think typically, you would stop doing colonoscopies and other things when patients get to 70 or 75. I would, if a patient has good performance status and has adequate life expectancy, I would actually tell them, don't do that. Continue even beyond the usual because of this increased risk of other cancers. I don't think the frequency of looking for other cancers by doing all of these preventative studies is any different in a CLL patient population. I think it's just that patients don't do it. And I think it's important that a CLL patient doesn't forget that these timely screening measures need to be done.
Right. One question has come up on the chat box is about infection prevention. How aggressive are you with that?
Again, I think it's, so what we have seen is in a patient who's newly diagnosed with CLL, roughly a quarter of our patients will have hypogammaglobulinemia. And even if you don't treat these patients, we have seen that another 25% of these patients who don't have hypogammaglobulinemia, as their CLL progresses, will develop hypogammaglobulinemia even before any treatment is given. Now, unless a patient has recurrent serious bacterial infections requiring hospitalization or repeated antibiotics, there is no indication to replete immunoglobulins by IVIG. However, I think it's important to remember that patients should get all the age-appropriate vaccinations, including those that are recommended by the CDC for immunocompromised individuals. And so, for example, pneumonia vaccines are not recommended in the general population unless they are over the age of 65. And so, we would say, no, even if you're in your 50s and have CLL, you should get it. Patients should get the Shingrix vaccination. It's a dead vaccine and it works very well in CLL patients as it does in the general population as well. So we don't have any specific sort of recommendations to prevent infections, except, all patients with MBL, CLL, SLL, even in the untreated stage, should be thought of as immunocompromised, and all the immunocompromised vaccinations should be given to these patients.
Thank you. Sumit, your questions.
Am I audible?
Yeah.
Thank you for excellent talk. I have two questions. So in myeloma, there is some data that for 17p deletion on fish, if we have a cutoff, say less, more than 55%, they do very poorly and others do relatively well. Is there any cutoff with respect to the percentage of 17p deletion on fish in CLL, which tells that some are good and some are not, some are really bad?
Thank you for that question. So there are some data to suggest it's actually 75% deletion 17p nuclei in CLL that may have a poorer outcome compared to those that have less than 20% deletion 17p, when you count 200 nuclei on fish. But in practical terms, I don't differentiate between the two. Anybody with deletion 17p, I would think of the same thing. There are some data also to suggest that double hit del 17p, meaning one allele you have deletion 17p and the other allele you have a TP53 mutation on chromosome 17, that's worse compared to having either of those abnormalities by itself. And so I do think that the burden of disease influences outcomes, but in practical sort of day-to-day management, I don't think that would really change my management, because even if I see 20% del 17p, I would treat in a similar fashion.
Right. And my second question was, if you have a CLL patient with 11q deletion and the IGHV is not known yet, or the report is awaited, so in such cases, if the patient requires treatment, you'll go by the TP53 way or something else?
So deletion 11q, you can choose, any treatment outside of the deletion 17p pathway. I typically will go with venetoclax and obinutuzumab in the frontline setting. I'm a big fan of time-limited therapy. I think it works very well, particularly in young patients. It's interesting, there are data to suggest that patients who receive continuous BTK inhibitor-based treatment with deletion 11q actually do the best with continuous ibrutinib. I can't imagine it being any different for acalabrutinib or zanubrutinib, but with continuous ibrutinib, patients with del 11q actually had the best outcomes even compared to deletion 13q patients and compared to patients with deletion 17p. And so, there is some suggestion that perhaps for these patients, you can do continuous BTK inhibitor-based treatment, but I don't think of it as a poor sort of risk factor anymore with the newer treatments. Certainly, if you have deletion 11q and you are newly diagnosed and don't yet need treatment, you're likely to have faster progression of disease simply because it's a high-risk marker.
Thank you, Sumit. Akanksha?
Yeah, thank you, sir, for the very nice talk. So I have a question regarding a patient. We recently had a case of CLL, and while he was on treatment, he developed a paraneoplastic pemphigus. So we treated the patient with the steroids and tried to give him IVIG as well, but actually there was no improvement. So I would just like to know whether, and even rituximab was given to this patient, and we were managing the patient in conjunction with the dermatology department. So in these patients, do the BTK inhibitors also have a role in the treatment? Or how is the outcome in these patients? Like they have an underlying pemphigus along with the CLL. He was a RICE stage 4.
Right. I'm sorry, did you say RICE stage 4?
Yes, yes.
Thank you. So that was my big question. I was going to ask, what was the extent of CLL? And it sounds like this patient had extensive CLL involvement, in the
Yes,
bone
sir.
marrow.
Yes.
So, I'm sure you all have the same thing. There's a case series of 50 patients with paraneoplastic pemphigus with CLL that I need to write up. Hopefully, I will get to it someday. How it is, right? But in that, what we have seen is, and this is an older sort of series of patients, BR worked very well. So bendamustine rituximab worked very well. We've also used RCVP without the vincristine. So rituximab, cyclophosphamide, and prednisone, that has worked very well. I think because a lot of this paraneoplastic process is driven by the CLL clone, right? If you can effectively get rid of the CLL clone with whatever means you have available, you would expect that the paraneoplastic process would also get better. So I can't imagine that Ibrutinib or venetoclax, etc., wouldn't work in a situation like this, but I just don't have any data to back that up. But my best, advice would be get rid of the CLL as effectively as you can with whatever you have available, and obviously dermatology for managing the skin lesions.
Okay, thank you.
Dr. Sachin.
Hello, Dr. Samir. It's excellent talk and complete overview of CLL. My question is from the lab side. So first is the MRD you are using in all the patients when you are treating the CLL. And other thing is, in your experience, what's the correlation between MRD CLL and clonoSEQ data?
Yeah, so thank you for that question. The way I am using MRD in my practice, so we have a excellent flow lab here, and so I will typically get a flow cytometry MRD at the end of fixed duration therapy. So if I'm doing continuous BTK inhibitor based treatment, then there is no point in getting an MRD because these patients don't get to undetectable MRD status. But if I'm using fixed duration therapy such as venetoclax and obinutuzumab or FCR or BR, then I will get an MRD at the end of treatment. I use MRD at the end of treatment as an important prognostic sort of marker and a biomarker, because many studies have actually shown that it's as good or in fact even better compared to some of our traditional criteria that we use to define complete response and partial response. And so if a patient has detectable MRD, they have a shorter progression-free survival after they stop treatment compared to patients who have undetectable MRD status. The current criteria are to use 1 in 10 to the power minus 4 as the cutoff for MRD detectable versus not. And that is what we use in our lab. And then I will counsel my patients and I will say, you have undetectable or detectable MRD. At this time, I don't change my treatment approach based on the MRD status at the end of treatment. There are many clinical trials that are ongoing and that will happen over time where we will test the question of, can we make a change in our treatment approach based on MRD results, and will that influence outcomes? It will be several years before we know that. So until then, I won't change anything. And then once I have checked MRD at the end of treatment, I then don't check it over time when a patient is in remission, because I only think it adds to anxiety. I think in a disease like CLL, I can examine a patient and I can look for lymph nodes coming back. I can look at their lymphocyte count going up, and even then a patient is not going to need treatment. So I don't see the point of checking MRD serially and worrying about this thing is going up, because it is going to go up. I know that. And the lymphocyte count will also go up, and that is better to see that as opposed to looking at MRD. With respect to the correlation to the clonoSEQ data, I think clonoSEQ is excellent. It will get you to 10 to the power minus 6. Yeah, which routine flow tests will not get to. Our flow can get us to 2 times 10 to the power minus 5, which is pretty good. We don't routinely test clonoSEQ as much as many other places might, because the current recommendations are 10 to the power minus 4, and I don't need 10 to the power minus 6. My flow can get me 10 to the power minus 4. And the most recent data from CLL14 study actually does not show any difference between outcomes if you get to 10 to the power minus 5 or 10 to the power minus 6. So 10 to the power minus 4 still continues to remain the standard. And that's why I think you can get clonoSEQ, no problem, but I don't think it would change anything that I would do.
So whenever you will get MRD negative by flow, only then you are ordering clonoSEQ, or means how, when you will decide when you have to order clonoSEQ?
I will order clonoSEQ on all the clinical trial patients because that's where it is. But in routine sort of practice, I don't order clonoSEQ because up until now, I haven't seen data that tell me that 10 to the power minus 6 is a superior, patients have superior outcomes if they get to 10 to the power minus 6. It's similar whether you get to 10 to the power minus 4, 5, or 6. Anything less than 10 to the power minus 4 is good, and that I can get from my flow lab. So then I don't need clonoSEQ. I hope I answered your question.
Yeah. Thank you.
Thank you. Dr. Muralidharan, I'll come to you in a minute. Professor Khan wants to ask something. He's our guest. Let's have his question. You are muted, Professor Khan.
Thank you, Dr. Sameer, for your very wonderful presentation, and you cover all the corner of the CLL. We learned many things. In the era of targeted therapy, we are now using targeted therapy in CLL, particularly in active disease. And almost all the drugs are available in Bangladesh also, BTK inhibitors, BCL6 inhibitor, and anti-CD20 molecular antibody also. My two queries, in stage 3, asymptomatic patient, platelet count is less than 100,000, but stable. Should I start the treatment?
Yeah, no, that's a great question, Dr. Khan. Thank you. Obviously there is a risk of immune thrombocytopenia that can happen in CLL. And so anytime I see a patient who doesn't have a high white count, or maybe even has a high white count but doesn't have lymphadenopathy, I will stage this patient completely. So I will get a bone marrow biopsy, I will get a CT of the chest, abdomen, and pelvis, and try and understand the amount of disease bulk that a patient has. In some patients, the bone marrow has 10-20% CLL, there is not a lot of lymphadenopathy, and their platelet count is 80, and they don't have a big spleen. I'm going to assume that this is likely immune thrombocytopenia and treat it as ITP, and sort of keep the CLL in the back burner. But if I see 60, 70, 80% involvement in the bone marrow, there are a few lymph nodes, and the platelet count is less than 100, then I might invoke the diagnosis of CLL as likely contributing to the thrombocytopenia, and then I might approach this as a traditional CLL patient requiring therapy. So I try to, in my mind, distinguish between, bulk that is for CLL versus not, and then approach the patient in that way.
Thank you. My second query is CLL patient with high count, that is more than 200,000, but without patient is asymptomatic and generates lymphadenopathy. That is stage, binary stage A or B. Should I watch and wait, or?
Yeah, I don't treat these patients, it is
count is very high.
Yeah. Even if it is 200, I will not treat them. I will observe them, and I will bring them back in 6 weeks or maybe 3 months and monitor their CBC. and I will not treat them. We've actually, had patients where they've gone up to 200, 250, 300, and we haven't treated these patients. I must admit, it makes me very nervous. It makes my nurses much more nervous than me, but, we will not treat them. I think these days, so let me just step back a little bit. So I think back in the day when, we had to use chemotherapy, FCR, BR, because of the toxicities, everyone was very nervous in starting treatment unless a patient really needed treatment. I think things are now better tolerated, right, with our newer agents. And so perhaps people don't wait until things get that bad. And so I think most people will start thinking about doing something or the other. But I really don't think that needs to be done. You can easily wait until a patient meets some of the traditional criteria for treatment. Even if their white count is 200, they're asymptomatic, I don't think they need to be treated. You can watch them closely and then treat when they do meet indications for treatment.
Thank you, Agrawal sir, for inviting me and arranging a nice topic. Thank you also, Dr. Samir.
To spare your time and join us from Dhaka. Dr. Samir, is progressively increasing disease an indication for treatment? So somebody has come to you with 40,000. After 3 months, he's 70,000. After 3 months, he's 100,000. Another 3 months, he's 150,000. So what do you advise that patient?
Yeah, so if you look at the 2018 IWCLL criteria for therapy, that actually is one of the indications for treatment, is a rapid doubling time. And you can choose 6 months or 12 months as the rapid, or the doubling time. In my practice, I typically don't use that because, again, if a patient otherwise doesn't meet indications for treatment, you don't need to treat. I tend to ignore this doubling time personally, but you wouldn't be wrong if you looked at it and chose to treat. I personally feel that if a patient is having such rapid doubling time, they are going to need treatment sooner than later anyways. I mean, anytime I see a new patient, I try to bucket them into one of three things. One is a patient that needs treatment right now because their white count is 400 and their hemoglobin is 8. Or a patient that has very low risk disease, that patient is likely not to need treatment for the next 5 years or plus. And so these are the two extremes. And then, I think everyone else falls sort of in between where I'm, watching them closely anyways. So then, even if they have rapid doubling time, I'm not going to treat them unless they actually have some other indications to treat. But that's my personal approach. And I don't think you can be faulted for using the doubling time as a reason to treat.
Thank you. Yeah, Dr. Muralidharan, sorry to make you wait. Come.
No problem, sir. Thank you so much. Sir, I want to know about the treatment in an elderly patient, and a 79-year-old CLL patient with a known history of atrial fibrillation. She's on anticoagulation, and she is now having stage 4 CLL. So, how do you approach in those type of patients, sir?
Yeah, that's a good question. Thank you for that question. So I think, if I have access, so with anticoagulation, atrial fibrillation, BTK inhibitors are problematic. You can do, you can use BTK inhibitors, and we have done that. We would typically use either acalabrutinib or zanubrutinib, and we will lower the dose of both of these BTK inhibitors to 50%. And because it's easier to lower zanubrutinib, I typically will use 80 milligrams twice a day, along with anticoagulation. And of course, you can't use Coumadin or warfarin because of a black box label sort of warning. And so you can only use apixaban, which is my sort of anticoagulant of choice, use a BTK inhibitor. And I will reduce the dose by 50% of the BTK inhibitors. But I personally would, if I can, for this patient, use venetoclax and obinutuzumab because, it would work very well. There would be no sort of contraindications to proceeding with treatment with anticoagulation with Eliquis or any of the other blood thinners. So I would personally choose venetoclax and obinutuzumab if I have access to it. If not, and if you're worried about a BTK inhibitor and bleeding risk, then I think BR may also be equally effective in a situation like this.
Thank you, sir. One more question, sir. In the book, you are mentioned about the MRD analysis. So routinely you do bone marrow at the end of treatment, or you do peripheral blood MRD?
Yeah, thank you for that question. So there is about a 90% concordance between bone marrow and peripheral blood MRD assay. And so I typically will do peripheral blood only. The only exception is if I have used a monoclonal antibody, such as obinutuzumab, and if I'm checking for MRD within 3 months, then I think bone marrow is more sensitive. So if you're going to use venetoclax and obinutuzumab as the standard treatment in frontline CLL, your obinutuzumab is done at month number 6, and you're going to be checking MRD 3 months after completion of 1 year of treatment, which would be about 9 months away from the last obinutuzumab infusion. So in that case, you can easily use peripheral blood MRD, and you should be just fine. You don't have to subject the patient to another bone marrow biopsy.
Thank you, sir. One more question. So for clonosec MRD, if you have a chance to do clonosec versus flow MRD, you already answered that, like you go for a flow for time being. But if you have the approval, would you go for clonosec rather than for the flow?
Yeah, no. So clonoSEQ actually has been approved by the FDA for CLL, and so you can easily get it, reimbursed if you check for it. But again, I think there is no compelling data so far to show that 1 in 10 to the power minus 6 is better compared to 1 in 10 to the power minus 5 or 1 in 10 to the power minus 4, and a flow is much simpler, and that's why I prefer flow.
Thank you, sir. Thank you for that.
Thank you. Dr. Thanda?
Thank you for your excellent talk, sir. I'm from Myanmar. I have one question regarding the research transformation. When CLL or SLL change to aggressive disease, I would like to know how is your approach to this patient, including the remission assessment, sir?
If I understood your question correctly, you're talking about CLL becoming a more aggressive disease process?
Yes, research transformation. And how do you approach such kind of patients, and including remission assessment?
Yeah, thank you for that. So, that unfortunately remains a problem with CLL is the development of Richter's transformation. So I think, the vast majority of these are diffuse large B-cell lymphoma patients. Roughly 5% will have Hodgkin lymphoma. So if they have Hodgkin lymphoma, I will typically use ABVD. If they have diffuse large B-cell lymphoma, you try to do clonality studies to see if the large cell lymphoma is clonally related or unrelated to the CLL, and that can be done by BCR receptor sequencing studies. If it is clonally unrelated, that happens in about 20% of patients that have Richter's transformation, then I just go ahead with the large cell lymphoma treatment algorithm, because those patients do very well. In the vast majority of patients where it's clonally related, I then will look at what are the genomic sort of biomarkers and what sort of treatment has a patient received for their CLL in the past. But the general and the standard approach is an R-CHOP based regimen. And then, I will try to add something else to R-CHOP, particularly if a patient has high-risk CLL with deletion 17p, or if the patient has received multiple prior lines of therapy. And generally, I will either combine it with venetoclax if they have not received venetoclax in the past, or with a BTK inhibitor, R-CHOP plus BTK inhibitor if they have not received a BTK inhibitor in the past. And then, if the patient doesn't tolerate this or doesn't have a good response, then I will then go to a PD-1 inhibitor-based treatment and combine that with Ibrutinib or acalabrutinib. Eventually, we try to get these patients to an allo stem cell transplant as best as you can. With respect to the type of response assessment, it's a little bit challenging, but you have to use both the Lugano criteria for lymphoma and the IWCLL criteria for CLL. And you independently stage these patients using both the Lugano and the IWCLL criteria to assess response.
Thank you, sir.
Thank you. There's a question. What's the prognosis of CLL with SF3B1 mutation, and does it change your treatment?
Yeah, that's a good question. So right now, it doesn't change our treatment approach. So, regardless of whether a patient has SF3B1 mutation or not, we would treat the patient in the same way. In a newly diagnosed patient that has SF3B1 mutation, the time to first therapy is shorter compared to a patient who does not have that. But, this is a small study. This is the Mayo data that I showed you. I don't know if I can confidently tell you that it's an independent prognostic marker. It probably is, but I think we need to wait for more data to become available before I can tell you confidently that it's an independent prognostic marker.
Thank you. Another question is about prophylactic antimicrobials in elderly CLL whom we are putting on BTK inhibitors.
Yeah, so I think, in patients who have relapsed disease. So if they've received any chemoimmunotherapy and are about to start BTK inhibitor or any treatment, I would certainly consider the use of acyclovir and Bactrim. If a patient has hypogammaglobulinemia, and even if they don't require IVIG replacement therapy, I would consider the use of prophylactic antimicrobials, because it gives me a sense that these patients have a defective immune system, and so I would give them antimicrobials. Off the bat, in elderly patients who have never had infections, I'm not always recommending Bactrim or acyclovir prophylactic strategies, but I would also monitor their CD4 count. If I see lymphopenia, then I think it would be reasonable to add those.
Thank you. Other question is there any place to repeat FISH studies or TP53 mutation studies during the follow-up of a CLL patient?
Yeah, that's a good question. So generally speaking, IGVH mutation status does not change. So you just need it once. CLL FISH status, typically after chemoimmunotherapy, we would always consider repeating if you are about to start a relapsed sort of line of therapy. So second line treatment after prior therapy, we would always recommend getting a FISH study. I think even if a patient has had Ibrutinib in the past and they're about to start venetoclax or vice versa, always get a repeat FISH study and a TP53 mutation study, because it will inform you the duration of remission, not particularly the type of treatment that you may choose, but the duration of remission. In a patient, if let's say you get CLIPI or the CLL-IPI at the time of initial diagnosis, and they didn't need treatment, but then several years later, in the absence of treatment, now you're about to start first-line treatment, should you repeat FISH? And I think we've done this study where we have seen that the FISH changes in an untreated setting between 2 time points only in patients who have unmutated IGVH genes, and even that the risk is about 10% of a change in the FISH parameters. So you may be selective in that group of patients to check FISH again.
Thank you. Professor Khan, you have raised hand sign. You have another question? Okay, Sumit, you have another question?
Yes, sir.
Yeah, go ahead.
So you had made it clear during your presentation that you prefer obinutuzumab because it is a better and more efficacious anti-CD20 monoclonal antibody. My question is about rituximab. So 375 mg per meter square versus a higher dose, 500 mg per meter square. Your comments.
Yeah, so there was a phase 1 study that Dr. O'Brien had led, more than 2 decades ago, looking at 375, 500, 1,000, even 2,000 milligrams per meter square of rituximab in CLL. There was no difference with the higher dose of rituximab in outcomes. And so, 375 is typically used for the first cycle, and then it's 500 milligrams per meter square for the rest of the chemoimmunotherapy cycles, and that's what we typically use. There are a lot of people who think that obinutuzumab is better because we are using a very high dose of 1,000 milligrams. And it's given weekly for the first 3 weeks, and then it's given, monthly. And that may be true, but as a clinician, as I think about which is better, to me, the data are what the data suggest, and the dose is what has been used. And right now, it shows that obinutuzumab at the current prescribed dose is better compared to rituximab, and that's what I'm going to go with. I don't think we can increase the dose of rituximab in the absence of randomized data and think that it might be better. It might be, I just don't know enough about it. And I would much rather go with what, I see with the standard doses that are approved and what the clinical trials have done.
Right. One question is about pure red cell aplasia in a case of CLL. How easy it is to treat and how do you treat?
It is not easy to treat. It's a challenge. So generally speaking, if I see a patient with pure red cell aplasia, I will look for parvovirus infection. If I see parvovirus, I will give them IVIG and hope that it works. If there is no parvovirus infection, then I will try to understand the extent of CLL infiltration in the bone marrow. If it is extensive and if I have to treat the CLL, I will give them anti-CD20 monoclonal antibody treatments and then potentially venetoclax or even Ibrutinib or a BTK inhibitor and try and clear the bone marrow of the CLL to see if it can help the CLL and the pure red cell aplasia. There are reports of BTK inhibitor-induced pure red cell aplasia, so I keep that in the back of my mind. But if my goal is to effectively debulk the CLL, then I'll use anything I can lay my hands on to get rid of the CLL with the hope that the pure red cell aplasia can improve. If there is not enough CLL in the bone marrow, meaning it's like 5, 10%, 20%, and I see pure red cell aplasia, then I will try to use cyclosporin in that patient because I think that is likely a T-cell mediated process. And if I can use cyclosporin, I can hopefully improve the hemoglobin and the red cells. So that is my approach of treatment of pure red cell aplasia.
There are a few simple questions. Do you do anything about Ibrutinib-induced lymphocytosis?
No, that is actually definitely no. It is an expected thing. I get nervous when I see a white count go from 300,000 to 600,000, but typically it is completely asymptomatic and I would just leave it alone.
Right. So that covers all the questions in the chat box. If any one of the faculty present here has any other doubt, questions? If none, then okay. Well, Dr. Samir Parekh, thank you very much. You spared a lot of time. You educated a lot of people. And I'm sure that the care of CLL patients will be much better from tomorrow on this side of the world. And your fantastic experience and this exhaustive talk, followed by wonderful question answer session, has made us a little better in this field. Thank you. Thank you so much.
Thank you very much. Thank you. Bye.